What is MAC? Minimal alveolar concentration required to prevent purposeful movement in 50% of the patient when exposed to noxious stimuli. So we consider MAC as a depth of anesthesia unit, but it's not. Why? We'll discuss in the next slides. So we consider this as a unit. What does it mean, MAC? ISO-MAC is 1%, CO-MAC is 2%, and DES-MAC is a 6%. What is actually is 1%, 2% or 6%? What we set on the dial? No, it's not dial. It's end-tidal. So it means that if we achieve 1% end-tidal with ISO, 2% end-tidal with CO, and 6% end-tidal with desflurane, it means that 50% of my patient will not move to surgical stimuli. Clear? So it's not about preventing awareness. So when we are talking a MAC, when we are discussing the MAC, when we are writing the MAC in the exam, it always represents immobility. So it's a unit of immobility, not depth of anesthesia. And as such, we are achieving the immobility with the relaxant. So this is not required. So we should not accept MAC as our depth of anesthesia unit. Then what should be the actual unit? We have to understand anesthesia. What is anesthesia? Definition. It is a reversible loss of consciousness in which persons neither perceive nor recollect the noxious stimuli. So it's about the perceivance and recollection of the noxious stimuli. That is anesthesia. There are two components of anesthesia. One, actual component. Actual component means suppression of conscious perception of noxious stimuli. That is actual component. That has to be there in all anesthesia. Patient should not have awareness. That is our primary goal and mandatory goal. And the desirable, which is there or not, is fine. That is analgesia, hemodynamic stability, and muscle relaxation. These are the desirable components. Agar has come out with the conclusion that all inhalation agents possess two reversible conditions or provide two reversible conditions. One, amnesia. Second, immobility. Now, what is the dose of thiopentone as IV anesthetic agent? 5 to 7. And what is the dose of thiopentone as an anticonvulsant? 2 to 3 milligram. Dose is different to get different effect. Same way, the concentration required to achieve amnesia is totally different from the concentration required to achieve immobility. And when we try to achieve immobility, we are always overdosing our patient. Always. We need to achieve amnesia. Why? We all are special and different from all other speciality. No memory recall. कभी ऐसा हुआ है कि आपका पेशेंट बाहर आया और अपना नाम भूल गया? नहीं हुआ. That is the reason we are special. So there are two types of memory. Explicit memory, that is called conscious memory, and implicit memory, that is unconscious, total unconsciousness. When patients met with an accident and having a head injury, that is implicit memory. Many times not able to recollect what he is. And in explicit memory, there are again two types of memory. Episodic memory, that is memory of the event, memory of the procedure, memory of that patient in the OR, memory of the surgery. And semantic memory is a memory of its own existence in the world. Means my name, my relation with my wife, my relation with my brother, my relation with you. So we are focusing very pinpointly only on episodic memory. And only an anesthesiologist can do it, none of other specialists can do it. And that's the reason we are special. Unit should be MAC, amnesia. Amnesia is the anesthetic concentration required to suppress recollection of noxious stimuli in 50% of the patient. but it's not possible to measure amnesia. कैसे पता चलेगा ये amnesic है कि नहीं और कौन से डोज पे है कि नहीं? It's not possible to measure. So we have to rely upon another unit that is called MAC awake. So MAC awake is an anesthetic concentration required to suppress a voluntary response to verbal command in 50% of the patient. कैसे MAC awake define किया गया है? They have anesthetized all the patient. Then they have gradually reduced the concentration of inhalation agent. And they were giving the verbal command to the patient. And when patient started responding, that is plotted on the graph. And when 50% patient has responded to that verbal command, that is labeled as MAC awake. And MAC awake is always higher than MAC amnesic value. And that is the reason we should rely upon MAC awake. MAC awake should be the concentration. That should be the unit for depth of anesthesia. MAC awake can be easily calculated 35 to 40% of the actual MAC value of the inhalation agent. Considering that isoflurane MAC value is 1, 35 to 40 is 0.34 or 0.35 is a MAC awake. Sevoflurane 0.7 to 0.75. We can consider 0.75. 2% is MAC. Desflurane 2 to 2.6%. So now, should we consider this as our depth of anesthesia unit? Acceptable or not? No, it's not. Because, look at this. It's only for the 50% of the patient. What about the rest 50%? So Agar has again come out with the formula. If you achieve the twice of MAC awake concentration, none of your patient will be having awareness. None. And that is the concentration we should target for. And that is for sevoflurane 0.75 MAC awake, twice of that is 1.5. So if we achieve 1.5% end-tidal concentration with the sevoflurane, none of your patient will be having awareness. So that is the concentration for sevo. For iso, 1 is a MAC, 0.35 is a MAC awake, twice of MAC awake is 0.7. So those who are using isoflurane, target concentration should be 0.7% end-tidal. And desflurane is almost 4%. So again repeating, your target minimum concentration to prevent awareness for sevoflurane anesthesia is 1.5% end-tidal, for isoflurane 0.7% end-tidal, and for desflurane 4% end-tidal. If you are able to achieve this, none of patient will be having awareness. That is for sure. So now you know the concentration and dose of inhalation agent. So all of your inhalation anesthesia, your target concentration is again 0.7 iso, 1.5 CO and 4 DES. Someone is going to ask me a question at the end of the session. If I am adding opioid in my clinical practice, does it decrease the requirement of preventing awareness? Or I am using nitrous also in my clinical practice. If you look at the MAC, we know nitrous decreases the MAC. Opioid decreases the MAC. So what's the definition of MAC? What MAC represents? Immobility. So adding nitrous or adding opioid decreases the requirement of inhalation agent to achieve immobility, not preventing awareness. So opioid or nitrous do not have impact on MAC awake value. So whether you use opioid in your clinical practice or use nitrous in your clinical practice, your target concentration will remain same, 1.5 end-tidal with CO, 0.7 with ISO and 4 with DES. Whatever the addition you use in your clinical practice. So this concentration is to prevent awareness. So then why to use opioid? Why to use nitrous? How it is making difference in a clinical practice? So there are number of sibling of MAC we know. One is MAC line. Fine. Then MAC awake, which is lesser than the MAC line. 2 MAC awake is between the MAC and MAC awake. MAC, there is another sibling MAC analgesia. MAC bar, which prevents the automatic reflex. Fine. So that MAC analgesia and MAC bar is at the level of MAC or above the level of MAC. Fine. So if you add opioid, it decreases this MAC bar and MAC analgesia. Giving you a clinical example, suppose you are conducting a case, your end-tidal is 1.5 with the CO, and sudden there is a change in the pulse rate and increase in the blood pressure. It does not mean that patient is having awareness. You have maintained the optimal depth of anesthesia, but you have not controlled the MAC bar and MAC analgesia. That is desirable component. Analgesia, autonomic reflex control, and relaxation, these three are desirable component. So to take the desirable component in your control, you have to add analgesic, opioid. That's called balanced anesthesia technique. Only factor which affects, impact the MAC awake, that is age. So this is again interesting graph. This is showing 100% of the patient. This is showing variation of MAC, 0.5, 0.2, 1 MAC, 2 MAC, 3 MAC, like this. Now this graph represents awareness. This graph represents immobility. This analgesia, and this one hemodynamic stability, autonomic reflex control. So if you achieve this concentration, none of the patient will be having awareness. This concentration is a MAC awake, 50% is aware. This is 50% immobile. 50% is having analgesia and 50% is having hemodynamic stability. So this concentration, if you achieve this concentration, none of your patient will be having awareness. That is 2 MAC awake concentration. That is 1.5 CO, 4 DAS and 0.7 ISO. Now, by achieving this concentration, you are not controlling immobility, analgesia and autonomic reflex control. So that can be done by pharmacological method, or opioid, or relaxation, or regional. So when you are achieving the end-tidal optimal level 1.5 is CO, along with these three things, controlling this desired factor, that is actually called balanced anesthesia technique. For proper depth of anesthesia, optimal depth of anesthesia, CO 1.5% end-tidal, ISO 0.7% end-tidal, and DAS 4% end-tidal.